Hi, welcome to AETCM. Today we're going to discuss a case about a 57-year-old male who was brought in your ER with a alleged history of RTA, bike versus Y, within 30 minutes of the accident. Sir, shall we begin? Sir, our initial assessment, the patient was brought in a trolley, conscious but restless. Patient was taken into our ER in a spine board and log rolling was done following it. And coming to airway, airway with C-spine, airway was patent and C-collar was applied following it. And
what was the sensorium of the patient?
Patient was conscious but little restless.
Okay. So you said airway is patent.
Airway is patent.
On what basis you said the airway is patent at that point?
Patient was talking.
She was talking?
Yeah, talking means kind of producing sound but not
producing
talking.
sound. He was not talking.
Talking.
He was making some sound.
Making sound. Yes, sir.
So with that aspect you can say that the airway is patent.
Can go.
A sound can be a strider also.
Sir.
So, sir, your comment, sir.
Yeah, exactly. See, the mental, how will you assess the mental status of the patient? First thing, remember, GCS is entirely different. Mental status is different. So, AVPU. So, patient is awake, not only awake, in addition, alert. Both should be there. Two A's are there. Okay. Awake and alert. And then the other next one is obeying verbal commands. If it's not, he will be just ask him to open or put out the tongue, he will be obeying. See, even if it is not upset, you have to pinch and make a pain. So the pain, he will respond only to the pain stimuli. Fourth one is totally unconscious patient. Even for pain stimuli, he will not be. So this is called the altered mental status. When you are going for the disability part, you will be examining the GCS, GCS score and other things. Okay, what was the condition for you? So whenever we are receiving any patient, before jumping to airway breathing circulation, you have to assess the mental status. Is it mandatory or not? Why it is mandatory?
To know whether the patient is going to an impending arrest.
Yeah, so whenever any deterioration from one stage may happen. So for the baseline is most important regarding the mental status. So mental status is one of the indications that the perfusion is all right. Not only perfusion, oxygenation is also all right as far as the brain is concerned. And another indication for the perfusion is okay renal output, that is urine. So these are two important parameters. Just with this, we can say the BP is so far maintained good or not. Okay. And number two, see what will happen when the altered mental status, airway protection will be lost. So between the conscious and altered mental status people, what is the main problem is airway maintenance. So one, if he is unconscious, the tongue may fall back. So immediately when you are going to the airway, this point is already the patient might have vomited. See, the foreign materials not only being aspirated, before aspiration it will cause certain amount of airway obstruction also. Then only it will be aspirated. Okay, it depends upon the quantity, type of foreign material. So mental status is more important. Okay, and I just give a manual, whatever manual keep in mind about the C-spine. And then give a manual that will immediately relieve the tongue obstruction. Then you give oxygen if he is having adequate breathing. So this way the care should be going. Okay.
So we have an, what is the approximate age of the patient?
57-year-old.
Male who has been following an RTA. So that is a patient in front of you. So can you just go ahead and see what is the AVPU right now? He is alert? He is not alert.
Agitated.
Agitated. So verbal response we can just tell. Maybe V or P, that will be his score. So right now it can be verbal response. Whether he is responding to your commands, no. But he is making some sound. Maybe after some painful stimuli, he is making some sound. So it will be in the P category. So you have received a patient maybe in the P category and you have taken him in inside and you have to make sure that you have done the log rolling, you have said, and cervical spine immobilization has been done and you received the patient. But again, airway patency, as I told, we cannot assure that his airway is patent. Right now, he is maintaining maybe, but there is high chance that this patient who is only responding for a painful stimuli can go wrong with his airway at any point of time. So, we have to keep that in your mind. So right now the saturation might be maintaining. If maintain saturation, is it okay that his airway is patent? Does that assure you that? No.
No.
It is just assuring that right now the oxygenation is adequate. Maybe the reserve can go wrong and the patient might desaturate at any point of time. So that all those things you need to keep in mind. And there can be an oral secretions. Maybe due to head injury, the sensorium would be low. As to tongue fallback can be there. So all those things you should keep in mind. So that is the reason why in trauma still it is A, B, C, D, E. So protecting the airway is the priority in a trauma victim with cervical spine immobilization. So if you are not protecting the airway initially, then breathing will get affected, circulation, and finally the patient will go into cardiac arrest. So that is like in cardiac arrest, we always say CAB. Now in trauma, it is still ABC approach. So the approach have not changed in a trauma victim. Okay, you need to remember that. So airway patency, if it is not there, we have to assure that, make sure that his airway is patent or not, and if not patent, you need to do maneuvers. It can be just a positioning of the patient, maybe just an oral suctioning initial, or maybe at that point of time, basic airway adjuncts like oral airway or nasopharyngeal airway. So what airway you will prefer in this patient? This patient, you are feeling that its airway is not patent, or you want to place an airway device. Either you will prefer oral or nasopharyngeal. What will be your preferred adjunct?
Oral.
Why oral? Why no? Why nasal? This is, you remember that this is a trauma patient. So before you inserting any of these things, you have to make sure certain things.
In trauma case, there is increased chance for
See, this patient might be somewhere around not less than 8. I don't know. We have not discussed the GCS. Maybe the GCS is not less than 8. Maybe still his gag reflex is preserved. If we wanted to go ahead, we can think of and putting a nasopharyngeal airway. But again, you need to keep in mind base of skull fracture as one of your differential diagnosis. Maybe you are thinking, or there is a local trauma. By inserting an airway, it can aggravate. So in the trauma patient, it is little bit difficult. It is tricky to select an airway at the initial point of time, basic airway adjunct. But you have to be very sure that you are not inserting when you are suspecting a base of skull fracture, especially a Ryle's tube. It totally contraindicated that you should not be inserting a Ryle's tube when you have an patient with suspected base of skull fracture. So that is the thing. You have to be very cautious. Maybe a suctioning and positioning will be more than enough in the initial part. Maybe later on, you can think of planning for a definitive airway. Okay, fine, continue.
And coming to breathing, air entry was bilaterally equal. Respiratory rate of 18 was maintained per minute, and saturation of 100% in room air was maintained.
Saturation of 100% and respiratory rate of 18 per minute. And what was the breathing pattern? I wanted to know more of a breathing pattern rather than the rate. So when you are having a possible altered sensorium patient with an probable head injury, that's what we are suspect. When you have altered sensorium, definitely we are thinking in terms of an altered sensorium. Then he has breathing is fine now, but breathing pattern is more important. Why that is more important?
The patient may be there can be from trauma to chest.
See, just forget regarding the trauma to the chest at this point. That at that time it will be different. But I am telling you are having suspecting a head injury, and you are telling the rate is 18, and you are happy with the rate. But I am telling, I am more interested to know the pattern of breathing more than the rate. So what is the reason behind that? What are the different types of respiratory breathing patterns that you know of?
Bronchial.
No.
Head injury will cause increased vasomotor.
So what chain stocks breathing? When will the chain stock breathing will be there? Chain stock breathing, waxing, waning of breathing pattern. So all those things you need to see. So rather than just telling the respiratory rate, we are looking for respiratory rate for less than a minute, but we have to look for the pattern of breathing also. That is also very important. You need to keep in mind. You said chest injury. Yes, you need to think of chest injury. You need to look for a flail segment. This is a polytrauma victim. We are not very sure whether there is a chest injury is there or not. But when you are suspecting head injury, always pattern also you should keep in your mind. And also accessory muscles of respiration if it is getting involved. Or one side of the chest is totally not moving. Sometimes this can happen. Suppose you imagine this patient has got a head injury as well as a pneumothorax. Maybe due to the head injury is going to the respiratory depression. That is why the tachypnea part is not seen. So these all things can be seen in this patient. So you have to be more specific when you are just telling about the breathing part. Okay, fine. Since you said air entry bilaterally equal, we have ruled out a pneumothorax at this point of time.
And in circulation, the BP was over 158 over 80 mmHg with pulse
158.
over 80 mmHg.
Okay.
And pulse rate of 106 per minute.
Okay.
And mean arterial pressure of 106. Above
106. Map was 106. Okay. External hemorrhage. That is the next one. Any external hemorrhage?
left ear bleed was present.
Okay.
And no other external injuries were not.
So left
Not
ear.
just ear bleeding. What is the importance of bleeding in the ear? Where this skull might have been, which type of skull fracture might have been suspected?
Base of skull.
Basal skull. So this is the dangerous one to treat with high mortality rate. See whether it is blood alone or any mixed with CSF also. CSF, arteria and rhinodia. Okay.
So you have to be very specific. You are getting a sign of base of skull fracture in this patient. You are getting a patient with altered sensorium following an RTA. His sensorium is not very good, and you are seeing a patient with an ENT bleed also. So we are possibly dealing with a patient with a base of skull fracture. So what are the other signs of base of skull fracture?
Mastoid, battles here, raccoon's eye.
Raccoon's eye. Then
Then
we can have CSF rhinorrhea. So all those things you need to keep in mind. Epistaxis, CSF rhinorrhea, everything you need to keep in mind. Okay.
And the patient also had history of nasal bleed was also there, sir.
History of nasal bleed was also there. Okay.
So these are all the things when you are examining the airway itself, you should have done it. So not only external, the face and other structures, internal, just to open the airway from lip to all the inner parts. Just to have a scanning quickly. Is there any bleeding still continuing? What is the speed of the bleeding, the rate of bleeding? In collection, is there any clotted blood? Is there in the throat? All these should open the airway and then immediately clear the airway. Okay.
So what was the cervical spine immobilization done for this patient? We missed that.
Cervical spine immobilization was done
with a Philadelphia collar?
Yeah, sir.
With a hard collar?
Yeah.
Okay. Why cervical spine immobilization was done for this patient? What is the reason behind? You're seeing a patient with altered sensorium. Somebody has asked to put a cervical collar. So what is the reason behind?
This having a dangerous mechanism of injury.
Dangerous mechanism of injury, okay.
Yeah. And
suppose you have a patient with dangerous mechanism of injury, is completely conscious oriented in front of you. So what will you do at that point of time?
Nexus
That's what I just wanted to get you to the Nexus criteria. One of the criteria is that Nexus criteria, you need to immobilize the cervical spine. So that is mandatory. You need to remember that mandatory, you need to do the cervical spine immobilization. Either there is a posterior cervical line tenderness or else there is an, what else? What are the other parameters?
neurological deficit.
Any focal neurological deficit, then under intoxication of alcohol or any other drugs, or there is an,
tenderness.
we have already covered that, altered sensorium, or else you have an distracting injuries. If any one of these things is there, you need to protect the cervical spine. So ideal in trauma scenario, you need to have an hard collar. In terms of an ideal, we can call it as Philadelphia collar or ultimate collar. There are different types of collars available, and you need to measure it, and you need to put an appropriate size of the cervical collar. That is again very important. You should not be putting a small size for those who need a larger one. So you need to put an appropriate sized cervical collar for a patient suspecting with cervical spine injury. And what is the percentage of patients that can have cervical spine injury with an blunt trauma to the brain? What is the approximate percentage? 10% will have cervical associated cervical spine injury also. And when you will remove the cervical spine, the cervical collar, sorry. When will you remove the cervical collar? Suppose I'm sending the patient for a whole body CT. Whole body CT, the CT cervical spine is clear. You can remove the C collar. When you will remove the C collar? What time? So when, otherwise the question can be, when you can clear the cervical spine? Now previously we used to do X-ray. Now X-ray is not needed. X-ray is out. When you have suspicion of a cervical spine injury, you need to put the cervical collar, get an CT. That is the best imaging of choice. Or else you need to get it done. Ligamentous injuries can be there associated because the patient again in altered sensorium, ligamentous injuries, if you are ruling out everything, there is no ligamentous injuries also, that is the time you can clear the cervical spine and you can tell them that you can remove the cervical collar. Otherwise, if an agitated patient, there is a small ligamental sprain or anything, if they are moving in and around, they will go for an other injuries. And also you need to know something called as shivora. What is that? Spinal cord injury without any radiological abnormality. So that is more common in children, but that can happen in adult also. So shivora is the other one that you need to remember. So that is the time when you can remove the cervical collar. So cervical collar need to be maintained till the cervical spine is being cleared. So we are dealt with A, B and C. You said there is bleeding from the ear. Then what else? D, disability.
Disability, the GCS score was E2, V2, M5.
Okay.
And the pupil was 2.5 mm bilaterally sluggish reactive.
Okay. So we have a patient with, what will be the classification of head injury here? Mild, moderate or severe? Moderate head injury. Okay. So what is the criteria with GCS criteria? 3 to 8 is severe, 9 to 12 is moderate, 12 to 15 is mild head injury. So we are having a patient with a moderate head injury, but GCS of 9. Now the question arises, GCS of 9. What should we do for your airway? We are having a patient of GCS of 9. GCS less than 8 or less than 8, definitely intubation. GCS of 9.
Sir, there is a increased chance of impending failure, so it will be better if you intubate the patient.
So what are the problem that you anticipate? What are the problem that you anticipate in this patient?
Airway may become...
because of what? Because of what is the reason of his airway patency can be lost?
Low patient...
Which one?
One is tongue fold.
Okay.
Then regurgitation and aspiration can be there.
Okay, regurgitation and aspiration can be there. So this is again a borderline GCS patient. But whenever you have a doubt in mind or you are seeing a lot of nasal bleed, that again the patient would have aspirated that. So there can be bleed in the oral cavity also. So that's whatever evidences, whatever we are seeing from this patient, it is always best to secure the airway at this point of time. Sir, your...
Yes, airway is the first priority, unless there is some exceptions. Okay, so you have to make it totally, not only establish an airway, you should protect the airway. So protection will be only with an cuffed endotracheal tube with the cuff appropriately inflated. Okay.
So again, GCS of 9, maybe you can wait and watch. You are very confident that whenever the patient is getting sick at that time, but you intubate. But again, you remember that our priority in management of head injury is what? Avoid secondary brain damages. So the most important reason for a secondary brain damage is what? Hypoxia. So you don't want a hypoxia to set in. You don't want an hypotension to set in. So setting in hypoxia, then intubating, the outcome of the patient will be totally different. So before that itself, we can take a call and you can secure a definitive airway. So definitive airway, as I told, a cuffed tube inside the trachea. Whether it can be an orotracheal intubation or it can be certainly a surgical airway. That is also a definitive airway. But you have to have a cuffed tube inside the trachea. So what has been done for this patient at this point of time?
We also did an endotracheal airway was done, sir.
And rapid sequence intubation
was done.
RSI. So RSI, what are the steps of RSI that you need to be cautious for this patient? I'm not asking for a general patient. For each step, what are the preparations that you need to do? What are the drug selection that you will do here? All those things you can elaborate now.
In preparation, but we will have to look whether how's the, as it is a trauma case, we have to evaluate whether how's the is any obstruction or any case is there, and to likewise find the size of the tube.
Okay, so it's an adult male patient, you can choose 8.5, that is fine. But rather than evaluation, major evaluation, it's very difficult, like the Malambati score and all, it's difficult in this patient. What you can do, you can quickly look at the patient, you can look for the danger, facial deformity, any beard, any short neck, all those things you can do. In terms of oral cavity, maybe you will be able to do the 3-3-2 rule, but again it will be with the difficulty. 3-3 rule is a possibility. And neck, again, it's fixed because cervical spine, we are suspecting an injury. So we need to hold the cervical spine. We need to immobilize the cervical spine. So either you can do a manual inline stabilization during intubation by removing the cervical collar. So you have to anticipate. Remember that trauma intubation is always going to be a difficult airway securing because there will be a lot of blood. There can be a lot of aspirate. There can be foreign bodies. So trauma intubation is going to be difficult. So again, you cannot extend to some extent. You will be only able to do a little bit of extension due to the cervical spine injury, suspecting cervical spine injury. So you need to anticipate always a difficult airway for trauma. That's number one. Then what are the other preparation that you need to take in for? You are having some ENT bleed, okay, whether it can be an associated oromaxillofacial other injuries. We are not you have not examined the oral cavity. You have to see the oral cavity first. Whether there is an associated maxillofacial injuries also, you might not be able to pass on the tube. You will not be able to visualize the vocal cord itself. So at that time, you need to think in terms of your surgical airway. So always make sure that your surgical airway equipments, everything is kept ready. Your adjuncts to help for your intubation like gum elastic bougie, everything is being ready. Your ETCO2 monitor is ready. All LMA. If you are not able to intubate but able to ventilate, think about LMA. So always for any case you will do, but specifically for trauma patient you have to be more specific. Sir.
And other things you have to keep in mind when selection and dosage of the drugs. One is whether the patient is already under the influence of drugs or alcohol. See, accordingly the dosage may be reduced. And suppose the patient is being taken to nearby center and they give some sedative drugs, or that also should be kept in mind. So in order to adjust the dosages, this is more important. And it's a head injury, the selection of agents, at any cost you should not see that the intracranial pressure is further raised. And nowhere in any step the hypoxia sets in, as I was telling. See, what are all the important things which will cause secondary hypoxia? One is secondary brain injury, hypoxia, hypotension, seizures. The most important thing. All these things should be prevented or avoided. You should take care of it. Okay. So in such a way, you have to oxygenate when give the breathing assistance if necessary, and then select the agent. What are the agents which will cause raised intracranial pressure? Induction agent. Any agent?
Ketamine.
Pardon?
Ketamine.
Ketamine. See, that is again a controversy. There are certain schools, they totally telling we can use it. Certain schools, they are telling we should not do it. Okay, ketamine. Next option. See, the BP is normal. See, either etomidate with adequate analgesia. Analgesia part is more important. Why it is important? It's a sympathetic overactivity. See, when the stimulation, just to pass the laryngoscope, that itself will stimulate the upper airway inner structures, richly innervated both with the sympathetic and parasympathetic. So suddenly parasympathetic overaction, bradycardia and spasm, laryngospasm, bronchospasm, severe spasm is it. So sympathetic activity, increased heart rate and blood pressure. So this itself may cause further bleeding. It itself may be raising the intracranial pressure. So this should be completely abundant, all the sympathetic response. So we have to give adequate dose of analgesic and suppress this one. And muscle laxants also good doses. Don't give a reduced dose. Muscle laxant as far as possible, never reduce the doses. Only induction agents that may cause hypotension. Okay, that is, you have to be very careful. A good relaxation is always most essential, not only to put the tube very easily. Otherwise, off the muscle action, you will struggle a lot. Okay.
So we selected, which all agents were selected here?
Sir, initially fentanyl was given, followed by etomidate and procuronium.
Okay, so these are the agents that we selected here. And post-intubation, what are the major things that you need to take care of? Post-intubation.
Analgesia and sedation should be continued, sir.
Okay, fine.
And following post-intubation, as the patient is in he's having a head injury, we'll have to get a CT.
Okay, that's fine. I'm just telling you about hemodynamics again. The continuing with the hemodynamics. The common problem, you are using fentanyl. Sometimes the patient can go in for a hypotension. So these are the things that you need to prevent. So more than causing problems for the patient, we should not do any damage. Already there is a head injury. By creating hypotension, hypoxia, again you are worsening the head injury. So check the blood sugars, maintain that it is normal. There is no hypoglycemia, there is no seizure. You give a seizure prophylactic agent because it's a moderate head injury. So you give a seizure prophylaxis. Maybe after 1 week you can think of stopping the seizure prophylaxis. So that is one thing. Then the second thing what you need to do is remember that oxygenation should be perfect and hypoxia, and maintain a saturation of more than 90%. Ideal 95 will be very good. So this will be our target to prevent secondary brain damage and avoid any cost hypotension. What is the problem when you have hypotension? Why we are telling it again and again? Hypotension should be avoided. Hypotension should be avoided.
Cerebral perfusion pressure will be decreased if hypotension occurs.
Okay. So cerebral perfusion pressure is the key. So cerebral perfusion pressure is calculated by
Mean arterial pressure minus
intracranial pressure. So intracranial pressure we usually don't measure, but ideally for severe head injuries you need to have an ICP monitoring, guided therapy. But when there is a decreasing in blood pressure, MAP will fall down. So as a result, the CPP, that is the cerebral perfusion pressure, will fall down, affecting further perfusion to the brain. So that is the reason why what is the target systolic blood pressure in a patient with traumatic brain injury? It should be 100 to 110. 100 to 110. You need to remember this target. So by no point of time the blood pressure is coming below, systolic blood pressure is coming below 100. Ideally 100 to 110 should be maintained. Minimum. It can be sometime on the higher side, then you need to control it, but otherwise the bleed will increase. So 100 to 110 is the systolic blood pressure. I am not telling of the MAP, systolic blood pressure should be maintained. So after the intubation, what has happened? What all investigation? We just seen that this patient is having probable head injury, and we are just stuck with the head injury part. Whether we have done any other assessment, any other adjuncts that you need to do for this patient?
Exposure was done.
Okay, any other investigation I can ask you?
We did a fast, EFAST was done.
Okay.
And EFAST was negative, sir. No external and no internal any.
No hemorrhage was there is at present. Fast is negative.
Yeah.
You cannot say that there is no internal hemorrhage or anything. You can just tell fast is negative. Okay, then what happened to this patient?
Also we did an adjunct ABG was done just to rule out any hypoxia and in any lactate.
Okay, ABG, okay, fine. For a baseline you can do, but otherwise there is no, because you are seeing the oxygen. We can see the PCO2, whether there was already some PCO2 retention, whether he is going for an impending respiratory failure. That is the only idea we would have got. But anyway, we have already intubated him and secured the airway.
And then later on
CT was done. Okay, CT done. Showed what?
CT showed right SDH in the frontoparietal region.
Frontotemporoparatal region.
Yeah.
It can be frontoparietal region, it will be frontotemporal parietal region, because SDH will be tracking down and EDH will be into the suture lines. So SDH will be frontotemporoparatal. You have a frontotemporoparatal SDH. Then
there was bilateral diffuse SH was there.
Okay.
And also there was left parietal temporal region hairline fracture was there.
Okay.
And also left to external auditory canal.
There was a fracture. Okay. So he has come back from the CT. Now this patient is in front of you. So what are the things that you need to take care of in this patient? So the neurosurgery you have called. Neurosurgeon, they have come and seeing this patient. So that is done. So what are as a responsibility of an emergency physician, what are your primary things that you need to do for this patient? So we have got a diagnosis now. You have intubated and secured his airway. So
we have to prevent the brain edema, sir. And for that, we have to give anti-edema measures.
Before that, what are the basic things that you can do to decrease?
Head bend elevation can be done.
Okay, 30-degree head bend elevation. Okay.
Then avoid any neck compression.
Okay.
To prevent same, sir.
Okay.
Then we can anti-seizure measures can be done.
Anti-seizure measures. So drug of agent, either phenytoin, fosphenytoin or levetiracetam are the agents of choice. Usually after 7 days, you can think of stopping it. So it should not be continued like what we do for a seizure patient. It's just for a seizure prophylaxis. Then
we can give a 3% saline or a Manitol.
3%. When you will use Manitol? That is my question. When for all this patient will you use Manitol? So when is Manitol indicated? See, Manitol is an agent that will not have an effect always. When you are using it, you should be using it in a very difficult situation whether there is a raised ICP and the patient is going for a herniation syndrome, or else there is a significant midline shift. The patient will go for an impending herniation, then only you should use Manitol. So if there is a more than 5 mm midline shift and this patient is possibly pupillary asymmetry or a GCS of 2 has dropped, then at that time the patient is going for an impending herniation. 3% saline, yes, you can start, and you can target in high normal, that is 145. Around that 145, we can target 3% saline, that is okay. But Manitol, it should be reserved for the time being. Whenever you really wanted to use it, Manitol, at that time the effect will not be there. So how does the Manitol help in decreasing the cerebral perfusion or not the cerebral edema?
As the Manitol is hyperosmolar, it will intravascular volume will increase, brain edema decrease, and the other fluid in the brain will.
And it is also diuretic also. So initially, what does it help? It will, when you are giving 200 ml, it is an hypertonic saline, just like a hypertonic agent. Suddenly there is an increasing in the vascular volume, so cerebral perfusion pressure will improve, and after that it will remove some amount of fluid also. So these are the two things that you need to remember. So the effect, what is called as first effect, is called as rheological effect of Manitol. It is called as rheological effect of Manitol. You need to remember that. Then what are the other agents that you need to give? Sedation. You said regarding sedation. So what will be the ideal sedation agent here?
Morphine, Midas,
Benzodiazepine or
fentanyl.
What will be the ideal agent, sir? See, when you want to use the benzodiazepine, so no benzodiazepine is having analgesic action. He has to tolerate the tetracycline tube. See, muscle action will make the patient quiet, but it will never give any pain relief. So it should be, benzodiazepine should always be supplemented with fentanyl. Okay, analgesic should be supplemented. So ideal breaking depending upon the other hemodynamic aspects. So one is we can continue with midazolam. See, other agents like lorazepam and diazepam prolonged action. So we can't predict. So it is a controllable action combined with fentanyl or propofol fentanyl or propofol midazolam or propofol midazolam and fentanyl. So like that. Okay, propofol midazolam alone will not be again sufficient. Fentanyl should be an analgesic part, it has to play. So both propofol is not having an analgesia, benzodiazepine, midazolam is also not having it. So if we want to combine these two, we can combine with the fentanyl also. The main advantage of combination is if we are giving propofol alone, the dosage will be more. It may have a chance of causing the hypotension. So that could be avoided by a combination. Okay.
So that is the next thing. Then what are the other secondary brain damage? Whatever we have discussed, you need to prevent the secondary brain damage, seizure prophylaxis. So now when you will select, okay, you don't have a facility for a neurosurgeon in your center. So definitely this patient should be meeting a neurosurgeon immediately and he should undergo a surgery. So you need to refer this patient. So what are the criteria for the referral or criteria for a neurosurgical intervention?
Sir, if the midline shift greater in SDH, if the size is greater than 10 mm or midline shift greater than 5 mm midline shift, in EDH size greater
whenever
than...
there is a herniation, no doubt.
Yeah.
That is the first thing that you can easily remember. Whenever there is an pupillary asymmetry, any other features of herniation, immediately neurosurgical intervention need to be done. Or as you said, more than 5 mm of midline shift. So subdural hematoma 10 to 15. Some books say 15 mm, some books say 10 mm. So subdural hematoma 10 mm or 15 mm, more than that, or any time herniation or more than 5 mm of midline shift, definitely that patient should be taken up for surgery. And EDH, definitely they need evacuation. Burhole evacuation or whatever be there, definitely needs evacuation. And whenever you have a depressed skull fracture more than the thickness of the cranium, again those group of patients required an immediate surgical intervention. Or there is another indication will be CSF rhinorrhea and all, but maybe initially they need not immediately do any surgery, but later only they may need the floor repair and all those things to be done. So basically in a nutshell, head injury, as an AED physician, our priority will be to stabilize the ABCD like any other patient. But here when you have an hypotension for a septic shock patient, you can correct it. Just the organ perfusion for some time is getting affected. But here, head is already compromised. And on top of that, the perfusion is getting compromised. So that at that point, the brain injury that is going to happen is going to be tremendous rather than what is happening for a septic shock patient. So septic shock patient sometimes can tolerate an 80-40 BP. But a head injury patient having an 80-40 BP is going to be in trouble. So we need to give, just like any other trauma patient, give fluids and try to maintain an systolic BP above 100 to 110 mmHg. So that will be your nutshell. So what happened to this patient ultimately?
Patient was admitted in ICU and repeat CT was taken over the course of days, and right now there was a last CT which showed a midline shift of 4 mm, but no active surgical management was
not done.
advised.
Till now, he is under observation only. So 4 mm, again 5 mm will be definitely for a surgical management. 4 mm we can wait and watch. So maybe repeat CT. Again, who are tremendous to have this extension of this STS? Patient on anticoagulants, patient on antiplatelets agents. So they will be definitely bleed. There will be a double-edged weapon, because sometimes you immediately evacuate this subdural hematoma already on antiplatelets, they will re-bleed. Anticoagulants. So you need to understand that coagulation of that patient also. You need to send the coagulation profile and you see what is happening, whether platelet or maybe sometime TEG also. If it is a polytrauma victim, definitely TEG also will be helping you in that. So in a nutshell, head injury management, you need to divide mild, moderate, severe. So that will be the category. Securing the airway as for any emergency is the priority, and avoid secondary brain damage. And whenever you have raised ICP, features of raised ICP, you manage raised ICP with Manitol and other sedative agents, 3% saline. And there are simple things like head and elevation and all those things. Seizure prophylaxis, yes, we need to give for at least 7 days. Phenytoin, phosphatoin or levetiracetam will be the agent of choice. Anything else, sir?
Sir, get a history of whether the patient is already on any antiplatelet.
So the patient has a known case of diabetes, hypertension, dyslipidemia, not on any antiplatelets or anticoagulants.
See, in any injury patient, this is one of the things you should never forget. Trauma patients. Okay.
So definitely when we would have discussed regarding the sample history, we would have mentioned that, but since short of time, we just rushed through the case presentation. Okay. Thank you.